Welcome to Decoding Healthcare Research. I'm your host, Efrain Riveros, Dr. E.F. Rain. Today, we are going to be discussing vitamin C. And we have the honor of having with us Dr. Peter Eck. He is an associate professor for the Department of Food and Human Nutritional Sciences at the University of Manitoba, Canada. Welcome, Dr. Eck.
Thank you. It's my pleasure to be here.
Thank you. We are going to be discussing a paper that he published in the journal Advances in Food and Nutrition Research in 2018, and it focuses on a very comprehensive review of vitamin C in human health. So the first thing I want to ask you, Dr. Eck, is what is vitamin C? For those who are not experts in the topic, including myself, we know that it's just one more vitamin, but why is vitamin C important?
Well, the importance of vitamin C, good question. It is a cofactor in a couple of enzyme reactions, which determine maybe your mood, actually do determine your mood. It is important for enzymes in collagen synthesis. So most of the people are very, very familiar with the term scurvy. When you have scurvy, that's the deficiency syndrome for vitamin C, which every vitamin has one. Your collagen doesn't form well, so you have skin problems, bleeding. So it has a very specific role in creating the collagen links, amongst others. It is important, as I said, in a few enzymes, but most people associated it with antioxidant function. So it is also an antioxidant in the human body as a vitamin antioxidants, and there's a few of them. There's also vitamin E coming to everybody's mind as well. But vitamin C is in the water-soluble fraction, in the cytosol of a cell, where vitamin E is an antioxidant for the lipid fraction for the plasma membranes.
I see. And vitamin C has been associated with multiple health benefits, right? And the most common use that people are aware of are to prevention of common cold and this type of diseases. But definitely, the application of vitamin C goes well beyond that. But before we go deeper into those aspects related to disease, I want to ask you, where can we find vitamin C? And I know that some animal species are able to synthesize it de novo, but human beings are not able to do so. So what are your thoughts about it?
Yeah, so my thoughts about that. Very good sort of question. Yes, most animals can synthesize vitamin C. So it's just a metabolite they can make when they need it. Humans have lost an enzyme in the synthesis pathway, so they cannot make it anymore. And some fruit bats also, some fish also have that. Guinea pigs, as a model, have lost that enzyme. So we have to acquire it from the diet. I guess we lost the function of that gene because there was an abundance in the ancestral diet we have. Where do I find it? Fruits and vegetables is always a great keyword. I find it in fruits and vegetables, right? The peppers is a very high source. Citrus fruits, as everybody knows, since it was sort of detected or first discovered in citrus fruits, not knowing that it is a vitamin in early sea voyages. So fruits and vegetables, but it is also as an antioxidant actually added to a lot of other food components, like it is in a lot of sausages, very funnily. It is as an antioxidant stabilizer. It is in many beverages. So it's pretty abundant right now.
So once you consume vitamin C in your diet, I assume that molecule is initially not active. So what's the process for it to become actually useful and active at the tissue level?
Oh, well, if I consume the vitamin, there's two forms of vitamin C, three forms. There's ascorbic acid, which is the active form. There's also the oxidative product, which is dehydroascorbic acid, which cannot also enter the body and will be reduced by the body's reducing capacity to ascorbic acid as the active form. And there's also a radical form, aka antioxidants, right? Free radicals. In that field, it can scavenge free radicals, but it can become a radical itself. So what should I say? So should we start with when we eat it, we don't have to digest it. It is free, so we can absorb it. Actually, that was absorption and distribution in the body is a key focus for 20 years in my research, because I worked on the discovery of the transporter enabling that absorption and the transporters enabling the distribution to every cell. So basically, it is absorbed very, very readily into the body and then distributed to cells through transporters I'm working on as ascorbic acid. So we have the active form as ascorbic acid. We can distribute that very readily to the cell. Once it enters the cell, it is there to be used by the enzyme reactions or to be used as an antioxidant.
As an antioxidant. So, and it affects some proteins, right? Like collagen you mentioned. And what other metabolic processes can be affected by vitamin C?
Collagen synthesis, yes. It is aiding an enzyme that produces an amino acid that cross-links the collagen. It is aiding enzymes that produce certain neurotransmitters. It aids enzymes that produce other signaling molecules in the body relevant for certain things. So through research, we know, research on scurvy or maybe research of animals that lack vitamin C, we know it can influence your overall health by maybe influencing your immune system. Sort of a little bit of an off thing. It, of course, has to be there for your tissue integrity, for your bone health. It has to be there for your mood, because these neurotransmitters, they are in the brain, so they can affect your mood. They can affect your motivation. For example, in scurvy, we can see that people are not motivated to do things anymore, or when they're on the threshold of the deficiency, but they can still perform as good as other people in regard of energy output, metabolic output, how they work on a treadmill. They can do as well as people in full status, but they're not motivated. So the neurotransmitter thing is a big thing. And that was reported, very old reports from early voyages. The people are not, or the sailors were not able to motivate themselves to get out of bed, to do their work on the ship. And then they fell apart and they, went into deep scurvy, the tissue disintegrates and the bleeding starts and they start dying. So many, many things, but a few very specific things are affected by vitamin C deficiency.
I see. And let's talk about the antioxidant part. So I understand that that property has allowed vitamin C to be included in some therapeutic regimens. But what about because it in the process of activation, I understand that it kind of donates electrons, and in that process, at some point, can it become like an pro-oxidant, or is just antioxidant under all circumstances?
Great question. Depends on the situation. So the general notion right now is, in our body, in our physiology, the one really neat thing about vitamin C as ascorbic acid and dehydroascorbic acid, it forms a circle, right? In the cell, it can be oxidized, but it can be very, very quickly recycled. We call it ascorbate recycled, meaning dehydroascorbic acid, the oxidative product, is recycled to ascorbic acid. And the one hallmark that is super, super important in that process is it can be done by reducing equivalents from our metabolism, meaning we can use energy to reduce ascorbic acid back in its active form when it's oxidized to dehydroascorbic acid. So in the cell, I would say 100% antioxidant because of these specific mechanisms. Now, if you put it, for example, into a product, right, and it's oxidized, of course, it can enhance the shelf life, but if the oxidative capacity is overwhelmed, it can also be pro-oxidative. So you can also have in a test tube a setting that you can oxidize other substances because it has a radical form, and that radical form, yes, can scavenge or can get electrons or can give electrons away easily. So it can harm other substances. Having said that, that's the pro-oxidant state you're referring to. Having said that, I think we can easily do that in a test tube, but the body itself with a recycling mechanism really makes really sure that it's an antioxidant and not a pro-oxidant in our body, in our cell.
Excellent. That is super, super important. And I also want to point out something that I read in your paper about the effect of ascorbic acid on absorption of iron, because for some people that is kind of useful, right? Because if you can improve, sometimes patients with hyperchromic anemia find that the supplements don't really work. Could vitamin C facilitate this absorption of iron?
Yes, actually, I think there had been traditionally a lot of research on that. And the iron has two forms. It has an oxidized form and it has a reduced form. And they use different transporter systems in the intestine. So, different proteins are utilized. And the oxidized form is not transported as well as the reduced forms of iron. Now, if ascorbic acid is in the system and the iron comes into your gut as oxidized iron, it can interact with the iron and reduces it, so it can be better absorbed, so it goes into your system better. And there's a few funky, because I'm also working in nutrition and we do textbook knowledge already and teaching. Even in my first year classes, I say, hey, there's really nice combination if you want to enhance your iron absorption with vitamin C. Eat peppers and the iron source together because peppers have so much vitamin C, right? So there's a few really nice food combinations you can recommend. For example, peppers with iron sources have the best absorption, or citrus fruit with iron sources. If you don't want to go for supplements, it's a very good choice to enhance your iron absorption if you want so.
Yeah, you're talking about supplements and dietary intake. My next question is, how much vitamin C do we need? But what should be our normal intake?
Yeah. Okay, that's surprisingly still a little bit of a contested issue. So the recommendations over the last year, or over the last 20 years since I started working on vitamin, or 25, 30 years, had been changing. So they had been elevated. They were lower initially. They had been changing. A few very nice data from Mark Levine, in which lab I was a postdoc on human kinetics, changed the notion of vitamin C absorption and distribution and how we reach the optimal levels. The bottom line is they had been updated. So the current recommendations here in Canada are 90 milligrams per day for men and 75 for women. Other countries actually have elevated that to 100 or 120 milligrams per day based on these latest pharmacokinetic or nutrikinetic data. So how much do we need? If you want to trust the current recommendation, if I'm a man, 90 milligrams per day. If you trust the recommendation, for example, in Europe and Germany, 120 milligrams per day. So in that ballpark, so around 100 milligrams per day seems to be sufficient for that.
And are you able to achieve those levels with just diet, or you necessarily have to add supplements?
No, there actually is no problem with the diet we have currently here in Canada or in the US or in Europe to achieve that. So if you're conscious and you follow the recommendation, like we have the Canada Food Guide, we have food guides in the US, you will achieve 100, 120 milligrams per day. So the other question is, does everybody needs these 120 milligrams per day, or do some people need more? And that's a completely different topic, which is unfolding right now.
I see. And if, in the past, hypovitaminosis were a problem and vitamin C was included. But in the Western world, how prevalent is the deficiency of vitamin C?
You see it. You see case reports. I speak to physicians who are in emergency rooms or in normal hospital settings. You see it very seldomly, meaning the individual has to be, the food choices of the individual developing hypovitamin C, hypinosa, is very, very low, but it's not zero. You see them, and of course it can be treated very well once it's recognized. But in general, I would say you don't see it too often. But if you say, like, if you go on averages that had been reported, it is probably not as good as you think, because between the deficiency you see when people go to an emergency room and the optimal supply is always a little bit of a discrepancy. And in that, it lies, do you develop a heart disease? Do you develop a certain type of cancer? Do you develop one common syndrome, common disease? And, if you look at the data, most people in the population have adequate levels when you measure them, but quite a number do not have adequate levels. So in one hand, you don't see a deficiency too often. On the other hand, we can discuss, do we need to keep an eye on the population supply or the population consumption, because we want to prevent these certain common diseases that are coming in. And that's sort of a contended issue, and still a research issue we are working on today. How do we get the people to follow the recommendation? How do we get them to recommendation? Most people are in a good status, but no, if 20% are not in a good status, that's still, 2 out of 10, 20 out of 100 people. We want to get that better. So that's sort of the stuff we try to work on.
I see. And you mentioned that precisely because vitamin C is kind of omnipresent and is in many metabolic processes. So it sounds logical to think that if you are deficient of vitamin C, you may get sick. And several diseases have been associated with lower levels of vitamin C. One of them is cardiovascular disease. So what is the evidence linking low levels of vitamin C and cardiovascular disease?
Good question. So the association between cardiovascular diseases and vitamin C are coming from epidemiology. So for nutrition, we have very often epidemiology. Ideal would be if we had a lot of randomized control trials, which we in nutrition oftentimes don't have. So it's always a mixed stream when you say, okay, we have an association, we have to keep an eye on vitamin C, or we have a control trial and we have causation. We say, okay, we have randomized people, we have them over the years, and they develop either more biomarkers or the disease themselves, which is, of course, hard to do for reasons of funding. It is very expensive to do these trials. So if we come from the epidemiology, it tells us this is what it is. So of course, it's very hard to say what is the mechanism, because you can't have the patient there. You can't take the patients, analyze the patient, take their blood parameters, do maybe imaging and stuff like that, like you have in a control trial. So my best guess, or my best extrapolation on cardiovascular disease development is maybe there's something wrong with the collagen metabolism. Maybe there's something wrong really with the antioxidative damage, that cells get damaged and then they develop all these follow-up problems which we have in cardiovascular disease, where the arteries get blocked over time and so on. The specific mechanisms I cannot really tell you. In other words,
yeah, but it's fair to say that if you are consistently low in your levels of vitamin C, your risk of cardiovascular disease increases, right?
Yeah, the associations are there from epidemiology, exactly.
Perfect. And
Yeah.
what about cancer?
Great question. Again, epidemiology links low levels of vitamin C, and usually we take plasma levels in vitamin C to the development of certain cancer, not all kind of cancers. Like one prominent example is probably prostate cancer, breast cancer, colon cancer. So that's what we see from epidemiology. Again, the other thing we want to see as scientists, are they intervention studies that actually prove that? And again, there's a void of these intervention studies because the epidemiological studies are there. They can have confounders. So can we be 100% sure an association causes something? No. There's no clinical studies saying, okay, we randomized things, all the parameters are the same, except vitamin C supplies are not the same. Can we find an outcome like cancers or so easily? No, we can't, because it takes years and years to develop them, right? So I don't want to give you a super definitive answer. I again say, from the epidemiology, we've got these links between ascorbic acid levels and certain cancers. And that probably is then purely related to probably the antioxidant function in these cancer. Clinical research hadn't really proven that causality yet, but we have an association.
I see. So there is an association, and that's clear, and particularly with cancer and cardiovascular disease. So it stands to reason that that if you intervene with vitamin C, you could see some effects on these same illnesses. But apparently that's not the case, right?
Not sure what you are asking right now. So if I do an intervention,
No, basically, yeah. What I'm trying to say is, it's clear that low levels of vitamin C may be associated with these illnesses,
Yeah.
but the intervention with vitamin C not necessarily is associated with the successful treatment of these diseases, right?
Oh, yes. So I sort of rely, yes. So an intervention, as we would have in a clinical trial, we just don't see it. Yes. So we don't see the intervention or the long-time intervention in a clinical trial because nobody has done it yet. So yes,
Yeah.
so that's what I can conclude on that one. But meaning, if you're in a good status, it should prevent these major problems for public health. Yes.
I see. And one of the most intriguing aspects that I found in your paper are those related to certain genes associated with the transport of vitamin C, whose polymorphisms have been associated with some clinical implications. Can you tell us a little bit more about that?
Yes. So that has been a very long-term research topic for me. Actually, it started in 1999 when meaning in our lab, I worked at the National Institute of Health in the molecular and clinical nutrition section, focusing on vitamin C with Mark Levine at the time, when we started to discovering the ascorbic acid transporter genes. At the same time, we had pharmacokinetics, and they were hugely varying. So people with the same dose created very high plasma levels where others didn't do that. So we were thinking, hey, what can that be related to? And by definition, pharmacokinetics, one of the most important determinants of pharmacokinetics are the transport processes. So the transporters in the intestinal system responsible for the absorption of the whole thing, in the kidney responsible to keep it in for the reabsorption and for distribution. So we started working on them, and I was fortunately, the genes had not been described at the time to be able to describe the genes for humans. And that was the basis to sequence them. So we could resequence them and we could determine polymorphism. So genetic variations in these transporters. So very early work, we started doing that. And of course, once we discovered them, we could go to very specific population that was people with Crohn's disease, for example, with intestinal problems, with other problems, with certain cancers, and investigate associations of these polymorphisms in these transporter genes to the disease, and we found them. So as expected, we found many other associations were determined after. So that's basically the relationship of associations in these transporter genes to diseases. Now, if they do something with the transport, then that's other studies which actually we followed up as well. So we found some polymorphisms impacting on the transport capacity. So the logical reasoning is, for some people, the transport of vitamin C absorption, for example, doesn't function as well, doesn't go as well as for other people because of their genetic background of these polymorphisms, which are associated to lower transport. And then they don't build up the ascorbic acid levels in the body, and then they will get the disease. So that's sort of the logic path of logic reasoning we developed back then. So still working on that right now.
So, and that's interesting because now we go beyond the plasma levels, right? Everything comes to the genetic predisposition that you have to have those low plasma levels, right?
Yeah, well, the plasma levels are always the biomarker we measure, right? So certain variations in transporters, one prominent example is SLT23A1. So it's the solute carrier 23A1, which is the ascorbic acid transporter responsible for the absorption and reabsorption in the gut or kidney, respectively. So some polymorphisms in that transporter had repeatedly been associated, or one specific polymorphism, to be more specific, had repeatedly been associated with lower ascorbic acid level. Meaning, if the people supposedly have the same supply, but they have the good variation, they will have a higher plasma level than the people with the same supply with the detrimental variation. So the easy solution would be finding them and saying, hey, take a little bit more vitamin C, because let's see if that remedies, your lack of absorption or reabsorption in the kidney.
Yeah, it's exciting. So that means that your plasma levels depend on those transporters. Even though it's not part of the paper, what is your take on IV vitamin C? Because I assume that it bypasses the receptors, right?
Yes, exactly. It's always the key question. What is my take on pharmacological doses of vitamin C bypassing the absorption? So I've got a very, very distinct thing, because my students ask me all the time, and people ask me, it's very nice to have that chance to explain it here. What is my take on it? Well, vitamin C pharmacokinetics, which we had determined before, when we eat it, is nutrition. And the other one, when we give high doses of vitamin C IV intravenously, many people I know had done it. I have done it myself. It is not very toxic. Bypasses the limitation of the absorption in the gut, which is part of the bioavailability, and you have very, very high doses or very high concentration in the plasma. So, for example, what we usually see in the plasma is 70 or 80 micromole per liter in the plasma. So when you bypass the absorption, when we give vitamin C with an IV intravenously, we have 10 millimolar. We can go up to 20 millimolar, right? And that's a completely different animal, because there is sort of a threshold in the plasma determined by the absorption and the reabsorption in the kidney for a reason, which is stopping at 80 micromole per liter and not 80 millimole per liter. Mm-hmm. But people use it for certain application because it had been promising sciences in animal models. And now I think there's also clinical studies underway saying it can help in certain cancers, because at that point, the ascorbate is such a high concentration that it's, which I explained before, can be as a pro-oxidant, even in the body. Like I told you before, because we have all these recycling mechanism and control mechanism, it cannot be a pro-oxidant in physiological situations, but this is pharmacology. It's not a physiological situation. So you overwhelm your capacity and you produce some hydrogen peroxide, and that's linked to killing some cancer cells. So that's the mechanism that had been described before and repeatedly be described. Maybe it's upgraded a little bit recently. I haven't really followed it up because this is pharmacology of the thing, but it is linked to killing cancers. And now there's a lot of clinical trials with high IV doses of vitamin C specifically looking into that. So I'm looking forward to see the outcomes of that, because, you know, if it helps, if you already have a cancer and it helps in that cancer, why not? However, I personally try to stay away from that research and the interpretation of that research. I try to do the nutrition. I try to say, okay, can we actually improve our recommendation based on your genotype, or do we have to have genotype specific recommendations for vitamin C? So still a topic I'm working on.
Oh, that's awesome. Thank you for your voice as an expert, and I want to kind of summarize in a way all the contents of this great paper. So I want to ask you, what is the takeaway of this paper? Because you talk about nutrition, you talk about the levels of vitamin C in the context of certain diseases. How do you summarize it in a good way for our audience to take that message home?
Well, the paper should be a snapshot of where we are right now. So we went through a few things like the public health aspects, the definition of the recommendation, which is fluid, then maybe the latent potential that we maybe could have more, or we could have diseases still linked to lower ascorbic acid levels. And then it sort of tries to prime you for the future, because the status quo, also represented in the paper, is we have recommendations, one fits all for everybody. So there's no subgroups, there's nothing. Men have 75, women have 75 milligrams per day recommendation. Men have 90 milligrams per day recommendation. And that might change because of the genetic development for the future. And also, you know, what I sort of tried to stay away from was the pharmacological side, the cancer prevention, the cancer treatment side. It's not prevention anymore, it's treatment, or other treatment options for vitamin C. So that's the status quo. And the really main thing is I try to sort of summarize the status quo, but saying there's more in the future, right? That is my justification to do research, to find more. And yes, so yeah.
And I can say that I greatly enjoy reading the paper, and I highly recommend our audience to actually review it. The link to the paper you're going to find in the description of the video. And I want to close by saying thank you, Dr. Eck, for sharing your knowledge with us, your wisdom. And I think this is a great contribution to the understanding of vitamin C in nutritional terms. Thank you so much.
Yeah, so you're most welcome. In regard, going back to the paper, it is a few years old. Mm-hmm. So I'm working with my students to sort of update that information, and hopefully we've got a similar thing hinging on that paper and sort of giving the recent updates on what we had briefly discussed on, and what the outlook was back at the time and what it is now, or what the status quo is, and how we are going to move forward in the future. So I heavily appreciate that you are featuring this paper, and there will be more soon.
Thank you so much. Looking forward to watching what is coming. Thank you so much, and to our audience, see you in the next episode. Bye bye.